Well, hello. This is recorded lecture on Chapter 6, the calcaneus and ankle, where we will look at the anatomy of and the positioning for both the calcaneus or the heel and the ankle. This begins on page, when we look at the anatomy, this is actually in Chapter 6, and this can be found on page 214. So the calcaneus is the largest and the strongest bone in the foot. You can see it kind of has an odd shape. And then this is looking at the calcaneus, the tuberosity. So this is the bottom portion. This is the medial aspect, lateral aspect, and this is the superior aspect. And you can see there are three articular surfaces. You have the anterior articular surface, the middle articular surface, and then we have the posterior articular process. Okay, and all the little different pieces on there. So this is actually a right calcaneus, looking at it from the superior surface, so looking down on it. This also can be found on page 214. And when we look at the talus and the calcaneus, this actually says talus. This is the tarsal sinus, which is important when we do our medial oblique on the ankle. We actually look in that area. You see this, they're pointing out where we are. This is the navicular bone. This is the calcaneus here. And then you've got the talocalcaneal joint right in here, which again, that's also important when we do the positioning of the calcaneus. On the plantodorsal axial, we actually look for this joint space to be open. And then again, showing you the three facets, the posterior facet, which is labeled number 1, the middle facet, articular facet, which is number 2, and the anterior articular facet, which is number 3. When we look at the navicular, the cuneiforms, and the cuboid, again, just to show relation of where the calcaneus actually sits. So the talus is here, and that would connect with the tibia and fibula to form the ankle joint up here. And then you can see the calcaneus sits in the back here. It makes up the heel is typically what, as lay people, we refer to this as the heel, but technically it is your calcaneus. You can see as far as in relation, you've got the 7 tarsal bones, you've got the 3 cuneiforms, the cuboid, the navicular, the talus, and the calcaneus. So 3, 4, I didn't realize the pointer wasn't on this whole time. I'm so sorry. 3, 4, 5, 6, and 7 tarsal bones. And remember, the mnemonic for that is "Come to Colorado next 3 Christmases." So looking from the top down on the foot in this picture, and then looking from the medial aspect, or from medial to lateral. Since that's the medial cuneiform, you can see that that's on first digit side. So we're looking from here to here on this particular image. Some of the technical considerations when we do these images, we're at a 40-inch tabletop. We will use gonadal shielding. Again, you're on lower extremity. So sometimes the angulation of the tube, where we're angling posterior, or what we think of as cephalic, because we're going towards the patient's head, realize that you're directing the beam more towards the gonadal area of the patient. And so gonadal shielding is important. Not only is it important, but it's important to tuck it between the legs, especially on some of these where we're have quite a steep angle towards that area. You just want to make sure that you absolutely shield the patient, and that it's appropriate shielding, not just laying on top of them, but actually covering the anatomy you intend to shield. We should demonstrate 4-sided collimation. Again, we tend to be on a 14:17 IR or a 16:16. So especially with these digital IRs, collimation is vital to improve your resolution to improve the overall quality of the image. And on the digital IRs, they actually only read the exposed area. So you want to make sure you minimize the exposed area as much as you can. You always want to make sure you have the correct part and central ray alignment. Ideally, your part is parallel to your image receptor, and your central ray is typically perpendicular to your part and to the IR. And if it's not perpendicular to the part, typically they will tell us that the reason for the angulation is to make it perpendicular to a specific area of anatomy. And as always, we always want to include our proper anatomic side marker. Now that should be included in the original exposure, not annotated after the fact, because that is considered illegal anywhere. You can annotate anything other than the right or the left. Right or left have to be there at the initial time of exposure. As far as technical considerations, our KVP range is going to be between 65 and 75 for digital. We want a short exposure time to reduce motion. You want to be on small focal spots so that you get the best amount of spatial resolution that you can. So small focal spot and then short exposure time. There is no, with the calcaneus and the ankle, there are no breathing techniques. It's just a matter of the patient holding still, which depending on their injury might not be difficult for them to do, but sometimes depending on the injury and the pain they're in, that is challenging. Always an adequate mass. You don't want to use more than necessary. Typically, we prefer high KVP, low mass techniques, so it reduces patient exposure. And if the part measured over 10 centimeters, then we would utilize a grid. But typically with the calcaneus and the ankle, you are not going to find that the part measures over 10 centimeters. For the calcaneus, this imaging begins on page 237, and there are actually two views for a calcaneus. We do a planto-dorsal axial and a lateral view. So planto-dorsal, because you're entering the plantar surface of the foot and you're exiting the dorsal or the top surface. So planto-dorsal. Remember, axial typically implies an angle of more than 10 degrees. So we do a planto-dorsal axial and a lateral, and our technique is 65 kVp at 2 mass. Now, when we do this planto-dorsal axial, you want to start with dorsiflexing the foot. Remember, dorsiflex is when the toes are pulled back towards the tibia and fibula. So they're flexing their foot so that the plantar surface right here is perpendicular to your IR. Now, when I say perpendicular to the IR, what I'm trying to tell you is you want this surface right here of the foot to be perpendicular to this image receptor. So here's your IR, here's the surface of the foot, and you want it as close to perpendicular as you can. Okay. The central ray is 40 degrees cephalic, or 40 degrees towards the ankle, towards the heel. And your central ray is actually put to the base of the third metatarsal so that it emerges posterior to the malleoli. Now, what do I mean by that? This is the first time you'll ever see where they reference an exit point. Okay, so the central ray is 40 degrees cephalic, and here they're showing you what it looks like from the front. All right, so you want it to the base of the third metatarsal. Well, looking at the plantar surface, that's a little bit challenging. Typically where we look, if you think about it, the metatarsals are in here. So the base of the third, before you can see where the calcaneus begins, but coming down probably a little bit below midfoot. And it says it emerges posterior to the malleoli. So what you're looking at actually is this right here, it's exit point. Let me highlight that. You're looking at this exit point, this sidelight. And notice how you can see the malleoli right here. This is the lateral malleolus. Okay, some people say malleolus. Typically, it's a regional term, meaning where you where your instructor was from is typically how they pronounced it. I don't honestly remember where my instructor was from, but she always said malleolus. And like I said, some of the anatomy instructors will say malleolus. Either way, this is the area I'm referring to. So it tells us that the central ray emerges posterior to the malleoli. So here's the malleolus right here. You can kind of see the point of it, and it comes out behind that or above it, superior to the malleoli. Okay, so this is what it looks like from the front, and this is what it looks like from the side. These images are going to hang with the tib fib up. No, I'm so sorry. Well, they're going to hang, when you look at this, it's going to hang with the toes up. So this marker is actually correct. This is fine, except that it, if it's truly a right, then the marker should ideally be on the other side. But as long as it's the correct marker and it's not obscuring anatomy, then that's acceptable. When we evaluate this and look, again, the marker would be ideal if it was over here. Would be better, but it's fine. It's still the correct marker. Notice you need to visualize the entire calcaneus. So here it comes down, up, and the calcaneus actually is right there is the top of it. Okay, so pretty good. Could be a little more penetrability in here. The reason I say that is because it says there has to be no rotation, and you have to display an open talocalcaneal joint space. So where the talus meets the calcaneus, that joint space should be open. Now it's challenging to see on here, but I'll show you in the next image. It should be right in here is that talocalcaneal joint space, but you can't really visualize that very well. So this is what it should look like. So an open talocalcaneal joint in a radiograph and in an axial CT image. So this letter A, oops, no pointer. This letter A, this is the talocalcaneal joint space. Okay, this letter A, so it comes across and then up like that, just because of the shape of the calcaneus is kind of odd, so it comes up like that. Right, and then this same thing comes across. You can see how it's positioned here. This is the talus with that T on there. They're showing you the talus, and this is the joint space. Now this was done on a CT scan. This one is our radiograph. So ideally, you would want your radiograph to come out so that you could visualize that. And if we look back last picture, you can tell that it's there, but you can't visualize that. So not an ideal image, not a diagnostic image. If depending on what the injury was, a lot of times they'll order calcaneus when the patient has a heel spur, which is not evident on this particular image because you're looking at it from the plantar surface to the dorsal surface, but it's typically shown on a lateral. So if that's what you were doing it for, to rule out a heel spur, then this is probably fine, because where they're looking is actually down here. But if it's any other type of injury, in theory, this should be better demonstrated than what it is. Okay, so planto-dorsal axial, the central ray is 40 degrees cephalic, because the patient's head would be up here, so you're pointing towards the head, and it enters at the base of the third metatarsal, and it emerges posterior to the lateral malleolus. The second image that we do is the lateral, and it's actually a mediolateral because this is the medial aspect of the leg. So the projection is coming into the medial aspect, exiting the lateral. So they tend to refer to that as a mediolateral, as we have been talking about. So this lateral image, the central ray is 1 inch inferior to the medial malleolus. Okay, so medial malleolus, let me try and outline that for you. Medial malleolus is right about here, and central ray should be 1 inch below that. So pretty much right there. And it's kind of hard to tell because the central ray is realistically kind of coming off the patient because of the way they're angled. Now it looks like their foot is more oblique. It's really not. It's lateral. They just have the sponge there because the patient has to dorsiflex their foot. So again, the plantar surface is perpendicular to the IR. So in this image, the way we're looking at it, it really does look like it's an oblique, but foot tends to be laying all the way down. Sometimes you have to give the patient a sponge because if they truly lay their foot flat, it can actually over-rotate the foot so that it's not completely lateral. So that must have been the case here where when the foot was completely flat on the IR, this wasn't lateral. It was actually over-rotated. So they raised the foot and just put a sponge under there instead of making the patient try and hold that position, which would be difficult to do. They put the sponge under there. And on this one, marker placement is correct because you've got right marker lateral to the part, and it's going to hang in this direction with the tib fib up. Okay, so central ray, 1 inch inferior to the medial malleolus. And this can be found actually on page 238. And our technique is still 65 kp at 2 mass. All right, and the evaluation of the image on this, this is actually a really good lateral calcaneus. The only thing missing would be our marker. So ideally, marker would be over here. And when I was telling you that they can evaluate for a heel spur, I'll just draw it in here. A lot of times you'll have a patient will have a heel spur and it'll look like just a little jagged, almost like a little claw coming off the calcaneus. What happens is this area stabs into the soft tissue, causing extreme pain for the patient. It almost looks like this looks up here, only it would be down at the bottom, so that every time they step, it's extremely painful for the patient. All right, and this image can be found on page 238. So we've got the calcaneus here. You've got the calcaneal cuboid joint right here. This would be the cuboid, the tarsal bone. This is the base of the 5th metatarsal, which we said is important to visualize because that is a common site of fracture. We've got the navicular right here. Here we have the talocalcaneal joint. Then you've got the talus bone here, and this right here is the sinus tarsi, or the tarsal sinus. Again, when we look at ankle, that's an important area that we'll look at when we look at ankle. Okay, so this is just, if we were doing it for a heel spur, you're really only going to visualize that on the lateral. The plantodorsal axial is really not going to demonstrate that. All right, and those are the 2 images that we do for a calcaneus. Next, we're going to look at our ankle anatomy. And when we look at the ankle anatomy, if we go back and look at the ankle joint itself, these images can actually be found on page 216, figures 6.10 and 611. All right, and this is a lateral view. So you've got the anterior surface over here. This is the lateral malleolus. This is the fibula. This is the tibia. All right, and then you've got the posterior surface here. And this is the talus right here. So ankle joint right in here. All right, and then when we look at it anteriorly or from the front, again, you've got fibula right here, tibia here. So this is a right ankle that we're looking at. So this is the lateral aspect, like you're looking at the patient. So tibia tends to be on first digit side, fibula is on 5th digit side. So this is lateral malleolus, medial malleolus. The tibial plafond is the surface of the tibia that articulates with the talus to form the ankle joint. All right, and this right here is the Mortise joint, this open space that you can see right here, and it usually dips around like this. This Mortise joint is important when we look at the Mortise joint in one of the views of the ankle. We would have to demonstrate an open Mortise joint. Okay, so the distal portion of the tibial that forms the roof of the ankle is called your tibial plafond. So that's right here. That's the underside of the actual tibia. And that joins with the talus to form the Mortise joint. As far as just looking at some of the anatomy to review this for an AP ankle, this can be found on page 217. If we look, letter A, this is a right fibula. B, this is the right lateral malleolus. C, this is the open Mortise joint all the way along here. It's not really open right here because this is an AP ankle. So the Mortise joint tends to be open on either side, but not in the middle, because if you look, like this is open. If you look right here, this is actually obscuring the joint space. So you've got open here. You can tell that's open, and you can tell this is open, but this, it's open all the way to here. Okay, but this area in here, not open. So that's an AP, and that's common. It's okay for an AP, but when we do the Mortise, you're going to need to see this open all the way across. So when they say open, I kind of put it in parentheses because, or quotation marks, air quotes, because this is not open. And on an AP, that is acceptable. It should not be completely open. So if this is a Mortise view that they were doing, then it would need to be repeated because that is not an open joint space. D is the right talus. E is the right medial malleolus. Now this is on the tibia, so medial malleolus. Oh, I don't have the pointer. I'm so sorry. Talus, right medial malleolus. This is the tibia. And then F, this is the tibial epiphyseal plate. Okay, the epiphyseal plate, again, right here. So that means that this is a young person, a child, someone still growing. Because when the bone grows, it grows at the epiphyses, correct? And then that plate is the area, like a growth plate. That's typically what we refer to that as a growth plate. So these right here are not fractures, these are growth plates. When we look at the anatomy of a lateral ankle, okay, again, still right ankle. So we've got the fibula. Right here, letter A is the fibula. We've got the calcaneus, which is B. Looks like they have the start of a heel spur right there. C is the cuboid. D is the tuberosity at the base of the 5th metatarsal. So again, it's important to visualize when we do an ankle. You don't want to come in so tight with your collimation that you clip that, because that has to be demonstrated in there. E is the navicular bone. F is the talus. G, this is the sinus tarsi right here. H, this is the anterior tubercle. And then I, this is the tibia. Okay. When we look at the ankle joint, the axial view of this is on page 216. And this axial view is basically an end-on view. Like if you were looking, if you were the talus looking up. So here's the tibia, here's the fibula. This would be the front, and this would be the back. So you can see medial malleolus is here, lateral malleolus is here. And what they're trying to point out to you is that the position of the lateral and medial malleoli the fibula is more posterior. Okay, so notice how if this is the tibia and this is the fibula, notice how it sits back further. It's not even with it, it sits posterior. So if you took and drew a horizontal plane through the midpoints of the two malleoli, there's approximately a 15 to 20 degree difference from the coronal plane. Right, so coronal plane in the line between the middle of the malleoli. So you've got medial malleolus, lateral malleolus. If you drew a line between the two, and this is coronal plane, there's a 15 to 20 degree difference between the malleoli. And it's important, it's called the intermalleolar plane. Intermalleolar plane. And the reason that's important is because we typically rotate the lower leg and ankle 15 to 20 degrees in order to bring that intermalleolar plane parallel to the coronal plane. Now, what do I mean? I mean that if we rotate the patient this way, 15 to 20 degrees, their leg and ankle, then by doing that, does it make sense that this is going to come up so that you end up being even with the coronal plane, parallel to? So when this comes down 15 to 20 degrees, you're going to end up being parallel to the coronal plane. Let me do that again. Okay, so you've got the intermalleolar plane right here, right, this dotted line. And what they're saying is that it's 15 to 20 degrees away from the coronal plane. So if you rotate the leg 15 to 20 degrees medially, then what's going to happen? This line is going to end up coming down like this, right? That intermalleolar plane is going to come down like this, and the two are going to be parallel to each other. The coronal plane and the intermalleolar plane are going to be parallel to one another. So that's important when we position. And again, this would be if you were the talus bone looking up, this is what you would see. The articular surface at the bottom of the tibia is your tibial plafond. And then you've got the fibula, which sits more posterior. So you've got tibial plafond here that articulates with the talus. Fibula, it's more posterior. Coronal plane, and then intermalleolar plane. So when we position, we have to rotate the patient so that this intermalleolar plane is parallel to the coronal plane. Again, our technical considerations haven't changed. We still are 40-inch tabletop. Still want to make sure we use that gonadal shield, collimate on all four sides, correctly align the central ray, not only to the part, but to the IR. And you always have to have the proper anatomic side marker, right or left. Now, a routine ankle is 3 views. There is an AP, a 15 to 20 degree medial oblique. Remember obliques, you always need a degree and a direction. So 15 to 20 degree medial oblique, and this is done for the Mortise joint. Also do a lateral. So 3 images in a routine ankle. Now, when we look at the AP ankle, okay, notice it says for the AP, you want to adjust the foot and ankle for a true AP. So you want to make sure that the entire lower leg is not rotated, and the intermalleolar line should not be parallel to the IR. Okay, so you want the leg straight, you want the tib-fib straight AP, and remember, by the way we just looked at that, the intermalleolar line, when the patient is AP, it has a 15 to 20 degree, it's off 15 to 20 degrees from the coronal plane. So the intermalleolar line should not be parallel to the IR in this particular image. When you're doing that, the intermalleolar line, imagine your Your IR is under here, correct? Well, it'd be straight. Let's try that again. Your IR is going to be under here. Again, not straight, but the intermalleolar line, if that was the IR, is not parallel to it. And that's okay for this particular image of the AP. That's acceptable. Okay, so true AP, the entire lower leg should not be rotated and the intermalleolar line is not parallel to the IR. Your central ray is midway between your malleoli. So your medial and lateral malleolus. Medial malleolus would be on the other side. Those are the two things that stick out on your ankle that if you hit that, anything hits that, shopping cart, you have you ever accidentally smashed your ankles together and you'll smash both your medial malleoli together, like if you bring your feet together real quick, painful, not comfortable at all. So you find both of the patient's malleoli, which they typically stick out just like this, and you're going right in the middle of them. Okay, and marker placement, these are going to hang tib fib up. So marker placement is okay. Again, if it is a right ankle, then it should be to the right of the part, so the other side. But as long as it's there, it's acceptable. When we evaluate the AP ankle, you have to demonstrate the distal 1/3 of the tibia and fibula. You want the proximal half of the metatarsals to be included, and the medial and superior aspect of the ankle joint should be open. Okay, so again, this would be a right ankle because this is lateral, so this is fibula. So the medial aspect of the joint is open, and then a little portion of the superior joint is open. This right in here is not open. Okay, but that's okay because we expect that on the AP. And notice this, the way that looks is perfectly fine because you've got the entire foot up there. So this is cloudy or obscured. And then marker placement, ideally, would be over here. And you would have your right. Okay, so good AP ankle. Next, we'll do our 15 to 20 degree medial oblique. So again, degree and direction. So what you're doing, this is the one I was talking about where you're attempting to make the intermalleolar line parallel to the IR. So the intermalleolar line parallel to the IR. And this image is found on page 240. Central ray does not change. It's midway between the malleoli. And what I would tell you, which it's hard to demonstrate with just talking, but if you're the tech and you're standing at the other end of this foot, like you see the plantar surface when you're seeing this patient, typically what I will do to show you guys is to put my index finger of each hand on their malleoli, like one index finger goes on that and one index finger on that. And then I look at them, like when I'm over here, I kind of bend down and I look to see when I have my fingers, if this is properly positioned, then my fingers should be just like this to each other, even with each other, so that it's parallel to the IR. When you start out, when the patient starts out and the foot and the leg is AP, these are not going to be even. Okay, when that starts out, it is not going to be even. But when you rotate them 15 to 20 degrees, what you're trying to do is get that intermalleolar line parallel. So if we go back to that original image we looked at, when you've got your finger, all right, if I have my finger on my lateral malleolus and I have my finger on the medial malleolus, my fingers are not even. So when you rotate the patient this way, what will end up happening is that you'll end up with your fingers being parallel to the IR, and that's your goal. Okay, so when you put your finger on each of the malleoli, when it's properly positioned, your finger should be parallel to the IR. That's what your goal is. Right? Again, marker placement, not really ideal, just because you can kind of see it casting the shadow of the lateral malleolus there, and it looks like it's going to be close. And when we look at the image, okay, now the mortise, this view is done to open the mortise joint. So you have to have the entire ankle mortise joint open, which it is. If you look on here, you can see that this is open pretty much all the way across. You've got a nice open joint space in here. Okay, so fibula, tibia, talus, mortise joint coming right across. Medial malleolus, lateral malleolus. The proximal 1/2 of the metatarsals are included, which is fine, that's right in here. An open lateral and medial mortise joint. So lateral area is open, medial is open. That is a little obscured, but that is acceptable like this on this joint. You have to, if it's properly obliqued, then the mortise joint should be open on both the lateral and medial aspect. And the malleoli should be in profile, meaning when you're looking at this medial malleolus, it's in profile, and this lateral malleolus is in profile. Okay, and those exposure factors, that is a really pretty image. This again looks annotated, which is illegal, so it would have to actually be on the image when you made the exposure. So you would ideally want the marker placement to the right of the part. Oops. And marker would be like that. Right, and that is your 15 to 20 degree medial oblique. Our last view is a lateral ankle, and this image is actually found on page 242. And this lateral ankle is a medial lateral, meaning this is the medial malleolus. So the foot is, this is left, so the foot is laying out to the side. They do show you a lateral medial projection, but we not do that. We do a medial lateral. Okay, so medial, just like you would lay out the foot, lay out for an ankle, we're doing, or calcaneus, you're doing the same rotation, rotating the patient laterally to do a medial lateral ankle. Your central ray is to the medial malleolus, which is right here. And notice I said in here, you have to include the base of the 5th metatarsal because it is a very common fracture site. So you have to include that. Central ray perpendicular to the medial malleolus, but you must include the tuberosity at the base of the 5th metatarsal. So on this lateral ankle, you have to include the entire talus and calcaneus. Okay, so talus, calcaneus. You have to include the tuberosity. So I was pointing it out for you right here. This is the 5th metatarsal coming in right here, and the tuberosity is this area right here. So that has to be included on your image. Your lateral malleolus should be superimposed over the posterior half of the tibia, which it is right in here. And optimal exposure factors. This is actually a really good image of a lateral ankle. All right, the next slide I added just to show you guys. This is an accessory bone or an extra bone right here. Let me outline this bone right here. We don't normally see that in an image. So when it does show, that right there, and then I'll get rid of it. When it does show, sometimes it's been, techs will think something's wrong, something's a fracture, sometimes they'll do additional imaging on that, but this is actually called an os trigonum, which is an extra or an accessory bone that develops behind the talus, and it's a congenital defect. Now, if it's a congenital defect, it means that the patient is typically born with it. It's there from birth. It's not usually noticed until there's an injury or imaging required of that area, but this is an accessory bone that develops in either one or both feet. So sometimes if you were to see this, the radiologist might call for the opposite lateral ankle just to see if it ends up being in both feet or in one feet. Nothing to cause concern or alarm. It's just an incidental finding. But if you ever happen to see one of those on an image that you take, just know that it's not anything abnormal. It's just a congenital defect. And again, trigonum. The last views that I'm going to show you, these are called your stress views. These are AP stress views, and these are on page 243. And these are typically done by either an orthopedic doctor or a radiologist, meaning they're the ones that are actually stressing the ankle. You can see they're wearing a lead glove. They're not grabbing the area of interest, which is the ankle. They're grabbing the foot. And this is inversion stress, where the foot is going medially. And this is eversion stress, where the foot is being stressed laterally. This is the one I had mentioned, I think, before, where you set everything up and then you go get ready to make the exposure. The doctor, whether it's the orthopedic or radiologist, will stress the ankle, meaning that they'll tell the patient, don't move your leg. I'm going to pull on your foot to stress your ankle, but I don't want you to move your foot, or I'm sorry, don't move your leg while they're doing that. Not exactly comfortable for the patient. All right, so central ray is midway between the malleoli, and these are called AP stress views. You have inversion and eversion. And typically these are done to look for any pathology involving ankle joint separation because of a ligament tear or a ruptured ligament. All right, again, not comfortable for the patient whatsoever. When we look at the images, on this top image, this is an inversion. The toes are being, or the foot is being stressed inward. This is eversion, where the foot is being stressed outward. Again, both on the right, so bending it in, bending it out. So you have to demonstrate the distal aspect of the tibia and fibula. The ankle joint should be in the center of your collimation field, and optimal exposure factors. And honestly, this collimation is okay because you're not really clipping anything, even though it's a little bit dark over here, but a little bit more open might have been, especially if you've got all this room on this side, hardly any on this side. Now, when the doctor is stressing the foot like that, it's not uncommon for them to accidentally move it out of the light field, and a lot of times the light will have gone off by that point. So important to make sure you give the radiologist or orthopedic enough room from side to side so that nothing gets clipped, because the last thing you want is for them to stress the ankle and then it to be clipped, and you have to go tell the doctor and the patient, I'm sorry, I clipped it off, we need to do that again. Not a good time. All right, and again, these are found on page 243. So that concludes our discussion of the anatomy and the positioning for calcaneus and ankle. 2 views on a routine calcaneus, 3 views on a routine ankle, and then we also looked at the stress views of an ankle that would be considered additional images or specialty images. If you have any questions, comments, or concerns, please write those down and we will discuss them at our next live or class meeting. Thank you.